Tonight, the League of Women Voters of Alabama is excited to sponsor an online educational forum entitled Improving Maternal Outcomes in Alabama. It's really a great night to be having an event on that topic because I was made aware that today is Maternal Health Awareness Day, January 23rd of 2025. So what better day than that for us to have a program about how we can improve maternal outcomes in Alabama. This forum is going to be an excellent opportunity to learn more about the problem and why providing presumptive eligibility is needed and how you can communicate with legislators to pass an Alabama Maternal Health Act in 2025. At tonight's panel, we're going to learn about why presumptive Medicaid eligibility is critical to protecting the health of uninsured pregnant mothers and getting them the prenatal care that they need during the first trimester. And by doing this, Alabama could go a long way to improve maternal outcomes. And what are the opportunities that exist in 2025 during the legislative session to address this problem? And I'm really looking forward to hearing from our panelists about that. And what are some other solutions that could also help this catastrophe, this sad situation where we need to be helping our mothers have a healthy pregnancy. And so right now, I'm going to hand this off to Margaret Pace, who is with us from the League of Women Voters of Baldwin County. And I'm going to let her carry it from here and introduce the panelists. Take it away.
Thank you, Kathy. I'm Margaret Pace. I'm a family and appellate lawyer in Baldwin County, and I'm a member of our local league, the Baldwin County, Alabama League of Women Voters. And I'm lucky enough to have learned from our panelists a little bit today. We have representatives from both parties. We have representatives from our own state that are here to try to improve our mothers' health outcomes. And that is Representative Susan DeBose out of Birmingham and Representative Marilyn Lands out of Huntsville. And we have Dahlia Abrams, who is a certified birth doula and a founder of Birthwise in Birmingham. So tonight is going to be information about where we are in Alabama on our maternal health care, but it's also going to be ideas to improve it. And I would encourage questions and just put it in either the chat or the Q&A, and we can refer to those later on. But we're going to get started with our amazing panelists. First of all, I'd like Representative DeBose to be able to introduce herself and give an overview of what you find in maternal health care here in Alabama.
Well, thank you so much for having me here tonight, ladies. I am delighted to support this bill and support Representative Lands. I will have to say this bill has given us an opportunity to get to know each other, and I love finding opportunities to work across the aisle on issues that are important to our whole state, and especially what could be more important than women and babies. I have worked for educational issues. I've worked to support women's issues. And even though I've just been in the legislature for 2 years, I've really sort of found my niche in certain issues. And as you all may know, I'm very much pro-life. And I see this bill as a pro-life bill. That's my viewpoint of it. I know everybody's going to approach it from their own viewpoint, from their own perspective, and from their own background. But for me, as someone that's pro-life, as someone that believes life begins at conception, I feel like I have to be supportive of a bill like this that takes care of women and babies from the very beginning. So it's my honor to be here. I have to say I am not an expert in maternity health care. I am going to learn tonight along with all of you. I wish I could say I'd been studying for hours and hours like Marilyn has, and I wish I knew as much as she has, but I haven't done that. But I know enough to know that this is a very important issue. I know that Alabama is lagging other states in this issue. I know that we need to work to communicate and educate folks in our state. And I want to be a part of this important conversation and this important action that's going to take place statewide. Oh, do y'all want me to say where I'm from? Did I say I'm from Hoover? I live in Hoover, Alabama. My district is District 45. That's Shelby County, and I have some of Jefferson County and some of St. Clair County.
Thank you so much. We're lucky to have you here, and not just working on the one presumptive Medicaid coverage bill, but the numerous bills that you've had that will help maternal health care.
Yes.
And
thank you. I appreciate that.
I'd like to also ask Ms. Abrams to introduce herself and maybe tell us about your community work with pregnant individuals.
So thanks so much for letting me come be part of this panel. This is an issue that I'm very passionate about. And I want to thank everybody who's bothered to come out on this freezing cold night. At least you didn't have to leave home to hear about this topic, because I personally think it's really important. And thank you to both Representative DuBose and Representative Lands for spearheading this, for working together. We have so much work to do, and it's really it's really encouraging to be here and see this happening. So I've been working in birthing spaces for almost 30 years, but not as a doctor or as a nurse, and not from the healthcare system, but from the outside. So as a childbirth educator, as a doula trainer, that's what I've been doing. And so I think that I come with a perspective of what it's like to be a consumer in our healthcare system. And that's kind of the some of the information I want to share with you all tonight.
Thank you for filling in our gaps on education tonight, too. Lastly, I wanted Representative Lands to introduce herself and also, if possible, give us just a little bit of information about this presumptive eligibility bill and how you as a legislator can affect our maternal health care.
Thank you. So I'm Marilyn Lands, Alabama House District 10, which is Madison County, and newly elected on a special in 2024. So I kind of just dove right in and am still, I still have a steep learning curve, but so many of my colleagues have been so helpful, and it's really been lovely trying to find my way. And I really have been looking for places where I can work across the aisle to raise Alabama up and to build relationships with my colleagues. And I'm still learning about what we can do, what I can do in the legislature. But this seemed like a great place to start. There's two areas that I'm really feeling that I can champion, and those are maternal health and mental health. And this morning we held a press conference to introduce the bill, which was pre-filed on Tuesday, and it is House Bill 89, and it is the Alabama Maternal Health Care Act, is what we're calling it. And so very excited about it. We had a great crowd this morning, got a lot of good press coverage, and presumptive eligibility is really a way to get women into their prenatal care faster. And there's really two things we're presuming here. We're presuming that that you're going to be eligible for Medicaid if you tell us that I live in this state and my income fits into these requirements. And Medicaid has done a fabulous job of getting women, when they have all their documentation, into the system so much faster. But for many women, there are barriers to getting that information together. You can do it online, but for many women, they don't have technology access or they don't have internet access. So we presume that if you say you're eligible and meet the requirements, that we're going to go ahead and presume you are for 60 days. But we're also presuming that if you tell us you're pregnant, that we're going to say you're pregnant and that you don't have to have that pregnancy verification letter, which for people who can't afford that first physician appointment, then they have to go to the health department, which does a fabulous job, but they are understaffed, and it's just hard to meet all the needs. And so it can be 3 or 4 weeks before you get that appointment. And in rural areas, I think it's even worse because those offices aren't open. 5 days a week. They have limited hours. So we're going to go ahead, and when you call and say, hey, I'm pregnant, I need to see a doctor, we're going to presume that you're pregnant. And if you tell us quick questions that, yes, you live in the state of Alabama, and yes, this is your income, then we're going to go ahead and make that appointment. We're going to do that pregnancy check at the first appointment, and we're going to give you 60 days to get everything else in order, but we're going to get you started a long ways before you might otherwise be started. So I think it's a great way to begin to really improve maternal and infant outcomes in this state.
Thank you. That makes a lot of sense. But is there any way, Representative Bose, would you be able to give us a little bit more information about what the current coverage availability is and how long it takes to receive that?
Well, in my conversation with Stephanie Azor, the Commissioner of Medicaid, their perception in Alabama is that Medicaid is you can almost instantly qualify for it, that it's done immediately in the doctor's office, and that women automatically immediately start receiving care. So in their minds, there's not a lag period. And I don't know that that matches with the reality of the situation. So I think a lot of people in the Medicaid office don't necessarily see the need for this issue. And you know what? If there's not a need, then hey, there's nothing lost. But if there is a need, and if there is this gap, then why not jump in there and provide that gap? So it's a lot of education needed. It's a lot of communication needed. Doctors' offices need to say, hey, come on in. You're going to be, don't worry. If it looks like you're covered, we're going to go ahead and treat you. So they don't need to be afraid to go ahead and make that first appointment and make that step into the doctor's office. And I think that's what we're trying to do here. And Marilyn, you may be able to explain that better than I can.
Well, I think part of it, and like I said, Medicaid is doing a much better job, or has come a long ways. Everything is changing so much electronically and stuff. So they've done a lot to really speed the process up, and I commend them for that. But not every woman has. She may be paid under the table. I mean, she may not have that documentation. She may not have proof of her residency. She may not have it handy. She may have lost her driver's license. I mean, there are all kinds of reasons why that may not happen. But the other thing is, before they can ever get that first appointment, they have to have that pregnancy verification letter. So to me, the biggest thing is that we're presuming you're pregnant. And the other thing that I find over and over is that so many women don't realize that they're even eligible for Medicaid.
Right.
Pregnancy Medicaid is different. It's a change of status, and the rules are very different. And so that's another piece of it, is trying to inform women. And 11% of our women have no prenatal care. And that to me is unacceptable. There is so much we could do to improve outcomes if we got women in earlier. And I know we're going to talk more about that. But I think presuming that you're pregnant and not having to have that verification, because right now a doctor's office says we need that verification letter before we'll make your appointment.
Yeah, and they should just be saying, "Come on in."
Yeah,
when you get here, we'll verify it when you get here. The most important thing is, if you think you're pregnant or you're telling us you're pregnant, please come in and let us start treating you.
Exactly.
Right. So it's like a catch-22. You need an appointment to get proof that you're pregnant, but you can't get an appointment because you don't have Medicaid. Where we can all go to the pharmacy and spend $10 and pee on a stick and prove that we're pregnant. And it's the 21st century, so it's not that hard. And you're right, Representative Lands and Dubose, that things have gotten much better. It's now possible for people to apply for their Medicaid online. And if they do it online and they have all the stuff that they need, it's pretty much immediate and it's easy. If they can't do it online and there are certain things that get in the way, if they've done it before and they used a different email address and they can't remember what email address it was, and now they have a different email address, they get into this loop that they can't get out of, and they have to go talk to somebody, and there's not always someone in the office, and like you said, they're busy and underpaid and not enough people, so it can take a few weeks to get that Medicaid established. From the doctor's perspective, their concern is if I provide this service and then you don't get Medicaid, I'm never going to get reimbursed for this. And
Right.
so they're concerned about that. And that's why they want that proof of Medicaid. There are offices where they will start treating people right away, even now, and there are others where they won't. And their concern also is that if you have this presumptive eligibility, we start serving these people and then they don't bother to get their Medicaid established, and then we never get paid. And so there has to be some mechanism within this system, within the bill that we're passing, that requires the doctors to do what they're supposed to do, because there's some that do and some that won't. And then that also addresses their concerns of, do I need to hire someone to chase after people to make sure they don't? We have our ACHN system to help people get into Medicaid that works really well,
Mhm.
but the doctors don't. OBs don't know exactly that's not their job to know how that works. So we really need to provide them the support to reassure them that they will get reimbursed for the care that they're providing.
And that is included in the bill. And we have had conversations with the Medical Association of Alabama, and they are now reassured that we are taking care of the providers. So all good on that.
Ms. Abrams, would you mind sharing a little bit more about maternal and infant health here in Alabama?
Yeah, so I'm going to take you guys on a quick tour of the maternal health and infant health situation in our state, just so we all know what we're talking about. So I'm hoping my screen is shared and that y'all can see this graph. So the first thing that I think is really important is to put us in context with the other industrialized countries in the world. Most of us expect that the United States has the best healthcare system. We do a great job and our outcomes are wonderful. We need to compare ourselves to other industrialized countries, and that's what this graph does. So on the bottom, the axis on the bottom, it's showing us how much money we spend. And you can see that the United States is spending more than any other industrialized country on our healthcare. But if you look at our health system performance, how well we're doing, we do much worse than all these other countries. So when you look at the regular things that the World Health Organization looks at to see how are you doing with your healthcare, the United States is doing poorly, even though it's spending a lot of money. Well, let's see. Can we switch slides? We can. So one of the things that's looked at is the maternal mortality ratio. So this is the maternal mortality ratio changing over time in the United States from 2018 to 2021. It's been going up. So we are not doing well. Not only do we have a high maternal mortality ratio, higher than any other industrialized country, but our rates are going up. Hopefully this is going to level out a little bit. COVID was very, very bad for maternal mortality. We were also very slow in Alabama to uptake the immunizations for pregnant women. So we did very poorly in that regard. What you can also see here is the huge disparity between Black women and white women, that Black women are much more likely to die than white women related to pregnancy. So that's just to give you a picture of how we're doing, and we're not doing well. This is another way of looking at it. This is over time, 2018 to 2021. The reason I put this here is because I want you to see the actual numbers. We talk about maternal mortality ratio all the time. It's a really small number. We're talking about 800 people in 2021, again, because of COVID, higher. But this is the number of people who die in a pregnancy related to being pregnant. They hadn't been pregnant, they wouldn't have died. This is the numbers we're looking at, the actual numbers. The ratio is per 100,000 live births. So important to me to emphasize this, because I have people who call me and say to me, I'm really afraid that I'm going to die, especially Black women, because this topic has been all over the news, as it should be, but people don't understand what a small number this is. So yes, we have to pay attention to this, but it's still a very, very small number. Having said all that, we're doing poorly in the United States, and it's getting worse. This looks at the difference in race, like we saw just in the last 2 slides ago. But what I want you to look at here is also education. So if you just look at the blue bars, we're looking at less than a high school education, some college, and college. And for white women, that's the blue bars. The more education you have, the lower your risk of dying in a pregnancy-related death. What's shocking here is that for Black women, education doesn't help. And more importantly, a Black woman with a college education has a higher risk of death than a white woman who didn't finish high school. So we have to look at our social determinants of health, not just what that individual is doing. Her education is not protecting her. This is in Alabama. The good news that you can see on this graph is the red lines are 2016, 2017, and the green lines are 2018, 2019. Our Maternal Mortality Review Committee has found a reduction in the number of women who died in those 2 time periods, and that's great. But we still see this huge disparity between Black women and white women. And then the big take-home message from our Maternal Mortality Review Committees was that 70% of deaths could have been prevented in 2016 review. And in the review of the deaths in 2018 and 19, over 60% of those deaths could have been prevented. So this is where legislation can come in. This is where we can be activists and get out there and do something to make this go away. We're going to look at just a couple more measures. I'm sorry, I'm doing a lot of data. I'm really a data geek. So sorry to those who are not data geeks. We look at maternal mortality internationally to compare how countries are doing. We also look at infant mortality. And the infant mortality is the death of the baby in their first year of life per 1,000 live births. And here again, you can see that compared to other industrialized countries, the United States has the highest rate of infant mortality. So we are not doing a good job, even as we are spending more money than any other country. Here you can see the race disparities. Again, this is 2021 and 2022, and Black babies are 2 to 3 times more likely to die in their first year than white babies. I want to pause here for a moment and say that the problem is not race. The problem is the system and how it treats people differently who are Black compared to people who are white. It's not because you're Black you're not as healthy. It's because of how our system is set up and the kind of healthcare that people can get, stressors, social determinants of health, poverty, all of those things. If you're interested in how Alabama's doing, better in 2022 than in earlier years compared to other states. Sometimes we're the 49th and Mississippi is 50th. In 2022, we were doing better in infant mortality, but certainly not as good as we should be doing. Alabama's infant mortality rate is 6.69 in 2022, whereas the average rate in the United States is 5.6, so ours is higher than that. I'm going to switch over now to preterm birth, which is where we can really see differences with passing this bill. So this slide is just to show you that when we're looking at infant mortality, low birth weight and preterm birth is the second most common cause of babies dying in their first year. So we want to look at preterm birth. Can we address that? And again, Alabama does very poorly. And this is from the March of Dimes. They give us a report card every year. Only Vermont got an A. Alabama has consistently gotten an F every year for years in how we're doing with premature birth. About 7,000 babies are born too soon in Alabama every year. And there's sorry that that's covered. That's our preterm birth rate in Alabama is 12.9 in 2024. And again, there's a huge health disparity. Black babies are much more likely than white babies. So we need to do better. And that's where I really appreciate the work that you all are doing. A way to figure out what we can do is to look at what are some of the causes of preterm birth. So here's just some of them. And if you look at this, you can see where getting early prenatal care will make a difference. So if somebody has uncontrolled health conditions, they're not getting health care regularly. They have diabetes, they have high blood pressure, they're either underweight or overweight. Starting their prenatal care early in pregnancy gives that doctor time to help them to get these things under control so that they don't cause them to have their baby too early. If someone has a blood clotting condition, Getting that treated during pregnancy is critical to carrying that baby to term and having a healthy baby. Helping people if they get an infection while they're pregnant, if they're in prenatal care, that can be addressed. If they have stressful life situations, our OB clinics can match them up with community health workers and other resources that they need to address their health. And then we have to look at the cost. So why is this important? Not just for saving lives, but also because it's really, really expensive to have babies preterm. And you can see here, way bigger bar there, $32,000 is the medical cost of a preterm birth on average compared to $3,000. It's 100 times higher. So it's a huge difference. And in 2000, that's data from 2007. I was looking up stuff that's more recent, and in 2019, their updated estimate is the cost per preterm birth in 2016 was $64,000. And in Alabama, probably $60,000. So if you just want to do a quick back of the envelope calculation, we have about 58,000 babies born every year in Alabama, more or less. We have a 12.9% preterm birth rate in Alabama. So, and the average cost is $60,000. So we're spending $448 billion with a B, dollars a year on preterm birth in Alabama. So if that's not a good reason to pass a bill that gets people into prenatal care earlier to reduce their chances of having a baby too soon, I don't know what is. Okay. And of course, there's long-term impacts. When a baby's born too soon, it's not just the cost in that of how much it costs to give them care. It's not just their increased chance of dying. Even if they survive that full year, they have long-term impacts on their health in many cases. And we need to remember that. And that's long-term costs. And there's also costs to the family of taking care of that baby. So there's a lot of stuff that's involved. So I'm going to stop my share here. I know I talked plenty, and see where you all can move on from there.
Thank you so much for giving us a background and more of education on what is actually going on. Is there, you've listed numerous ways why this presumptive eligibility bill would help Alabama with the budget and perhaps individual families and mothers and babies as well. Representative Lands, is there a reason why you decided that this particular bill would be your first bill?
Several reasons. So I knew that my first task getting down to Montgomery was to build relationships, to meet my colleagues, to try to find common ground. And about the same time that I got down there, I was made aware that Mississippi had passed their bill on presumptive eligibility. And maternal health, because of my own birth experiences, has been very near and dear to my heart. And working in mental health and hearing stories over the years from women with their struggles to have a family, raise a family, to just to understand the how hard parenting is and how much support that they deserve in taking this endeavor on. So it just seemed like a natural fit. It was almost like learning today, is Maternal Health Awareness Day. Seemed synchronistic. Is that the word? And so it seemed like as I was looking for something that I could do, and I've got several things in the works, but this one seemed like one that was an easy way to begin to do something very positive that could create dramatic change and even save money for us, but also champion an area that's very near and dear to my heart. And one that's allowed me to make great friendships already with my female colleagues down there.
Speaking of that, Representative DuBose, would you let us know why you decided to co-sponsor this bill?
Well, sure. And first, let me commend Representative Lands. One of the things that I found out as soon as I got down there, and she's already learned it, the sooner you start working a bill, the more you learn. I mean, a lot of times you'll get advice that just says, let's just sit on your hands and listen and learn and watch the men work, and I think we were both the same way. We're like, no, we're going to hit the ground running. I didn't come here to watch. I came here to be active, and you've jumped right in on that. And it's been a pleasure to get to know you. And one of the reasons I'm really proud that we're sponsoring this is because, do you think a man would have picked up this issue? I mean, I hate to say that, but we have very few women in our state legislature. We have one of the smallest percent of women representation in our state legislature. I think we're in the bottom 5% of all states. Less than 20% of our makeup is female between both the House and the Senate. And so we have really an obligation to pick up these bills and carry them that men may not understand the depth. I mean, I think they'll be supportive, but they don't really understand it to the extent that we do, because we're the moms. We're the ones that have been pregnant. We understand these intimately. So I was happy to jump in on this. And as I told y'all, I look at it from a pro-life perspective. How can you say you're pro-life if you're not going to work on protecting a baby at conception? And that's what this is, protecting a baby and a mother. So, I was happy to jump in. We are early in the process. I don't know if you want me to talk about that yet, the process of where we are.
That'd be great.
Legislation. So Maryland has filed the bill. That means if you go online, Alabama legislature, and click on House members' bills and you type in lands, it'll be under there. The bill will be filed. It'll be introduced. You'll see that. You'll see the fiscal note. I believe, do they have that filed with it, Maryland? Your fiscal note should be with it, that shows what is the estimated cost of implementing this bill. So
I don't think they're there yet. I checked.
It's not there yet.
But
okay, it'll be there, and maybe they're still putting the pencil to that number. But you've also done the work of getting co-sponsors. So I'm a co-sponsor, and I know some of the other women are co-sponsors. I don't know who all ended up co-sponsoring it, because we had to do it sort of, we're not down there right now. So we had to try to get people to call in, put your name on it. It's not as easy as walking around and saying, hey, will you sign on to this? Because we're not actually in session right now. We're having to do all this communication through emails and that kind of thing. But some women, some people will go ahead and sign on. Just because somebody's not sponsoring it doesn't mean they're not supportive. They will likely end up still voting for it, but because a lot of people just look at co-sponsoring bill differently. If I'm interested in a bill, I go ahead and sponsor it because I want to start working it. I want to start being helpful. I want to start, if I see that there needs to be a change, I want to be part of that conversation to help make the bill the best that it can be. So I'm not one of those that shy away from sponsoring something if it's what I like. And other people take another view. Some people just say, I only sponsor what I'm going to carry. So you really can't read too much into how many sponsors you have. If you have sponsors, that's great, but that doesn't mean that you don't have support if you don't have a number of sponsors. But so she's done the hard work of getting the bill filed, getting co-sponsors. And then the next thing that's going to happen is that this hopefully will come before one of our committees, and hopefully health committee, because I'm on health committee and I would love for it to come before a health committee. It'll be assigned. It could also, I suppose, go to the Children's and Senior Services Committee. So that's Jenny Shaver's committee. She's chairman of that, which I think would be a good option. But we don't get to pick. So that's picked for us. That's assigned. And then you'll just see. Did it say yet what committee you've been assigned to, Marilyn? Has that come out yet?
Well, last I checked, it wasn't on Allison, but Kathy's just popped into the chat that she can now see the bill online.
Okay. Okay, good. And it may say
I cannot see it.
Oh, you cannot see it. Okay.
Can't see it.
Okay.
Well, it should be on there any day, and then we'll be able to see. They'll go ahead and assign it. We'll be able to see what committee it's assigned to. And then, that'll be important to start talking to the members of that committee in the House, make sure they really understand the bill, have personal one-on-one conversations with each member of the Health Committee, because it has to pass out of the Health Committee before it can go to the floor of the House to be voted on. And the same thing will happen in the Senate. I don't know if who's carrying that in the Senate or if you've gotten that far yet.
Linda Coleman Madison.
Okay, good.
Yeah.
Good. So she'll have the same process there. She can do it simultaneously, or it may be you first and then her. Sometimes there's just strategy to how you move it. Sometimes it moves simultaneously, or sometimes it can move through the House and then to the Senate. And you may want to, choose to do it that way, but it'll have to go through a Senate committee. It'll have to be assigned to a committee. The committee chairman will have to agree to hear it. And then it'll have to pass out a Senate committee, and then it'll have to go to the Senate floor too. So it's quite a process. It's not easy. It seems like obvious to us. It will not be easy. Nothing is easy. There will be difficulties that you never, think about, but it's just the process. It's just our process. And you just got to get in there and get started. And obviously, we'll have a big team of people behind us with the League of Women Voters, and I'm sure there'll be other groups that will be supportive. And we'll ask people in our districts to reach out to others, send personal emails, personal texts. I don't like form letters. I don't have time to read those. I like personal letters from my constituents. That means so much to me when I hear directly from a constituent, even if it's a phone call. Most of us answer our phones. Give us a phone call. My cell phone is on my website. I give it out and I try to answer it. Nobody else answers my phone. We don't have staff. We don't have helpers. It's just us.
So, Representative DuBose, you mentioned several, of the processes, that how it occurs, but you also mentioned a word that I would appreciate just a little more depth on, a definitional explanation of what the fiscal note is. And even though it's not there yet, what it means and what we can expect it to say in this bill.
So that is part of our legislative services duty, is if there's a cost to implementing a bill, they try to determine what that cost to the taxpayer will be. And that's called a fiscal note. And that's provided out there. And that's something that's taken into consideration. And that will be, frankly, a big consideration in this bill, because right now we're looking at a possible fiscal note of $1 million a year. And, there's some nuances in there after asking a lot of questions. When I was talking to the Medicaid commissioner, come to find out only 40% of that is actually state dollars and the other's federal dollars. And so I said to her, that needs to be explained in that fiscal note, because when a representative like me that just pulls it up and sees $1 million, they're like, oh, $1 million, but really it's 400,000. That's a big difference. So we need to fine tune, and that's something that, Marilyn will be working on, is fine tuning the accuracy of that fiscal note, asking questions. How did you come up with this? We need to go back and calculate it the way they calculate it. Does that make sense? Did they use, I think they used 4,000 patients and the average cost per visit of $135. They kind of ran through it with me, and it made sense. You just kind of give it a common sense test. But when they got to that million, and I started asking more questions and found out just 400,000 of the million was state dollars, that raised a flag to me that I felt like that needs to be clarified.
And I did call LSA and ask them to revisit that note.
Yeah.
So I hope to hear back from them. But
that's part of the process. All of this it's a process, and then we're going to be looking at budgets and budget shortfalls, and what's the budget going to be this year, and what's Governor Ivey's, what's her feel for the budget? Is she going to give us any wiggle room? Because really the budget starts with the governor, and that means the Medicaid budget starts with the governor, honestly, that it comes back down to us. So this one it'll be a budgetary issue until we can get that fiscal note really clarified and maybe brought down a little bit.
But I do think, as Dahlia so beautifully shown us, that the cost savings of this are really going to, so
I know.
cost
We
out of
see all that, and they're going to be, I'm just telling you, they're going to be looking at the current year cost because that's today's budget. And of course, we've got long-term savings. And that's, part of what we have to do with help to really fine tune what that savings is going to be and tell them, look, this is worth an investment in our future. This is an investment in our women and our children. The longer we put this off, the more expensive it's going to be to our state. So it's, that kind of analysis and conversation.
Representative Lands, could you continue your comment about how providers are paid for prenatal health care now and what this bill would change in Medicaid costs?
So the way providers are reimbursed, I call it a bundled billing, but it's, I guess, a package bill, a packaged cost. And so there's prenatal expenses, and then there's the birth expenses. And under Medicaid, I believe there are 12 prenatal visits, and it's just one cost for up to 12. And so that's another thing, because there are no exceptions to this. And so if a woman, had complications, if it was a high risk pregnancy or whatever, under Medicaid, you're not entitled to any more. And so sometimes they get rejected from their provider at that point. And that to me is unacceptable. I don't know how. I just, that's a piece of it I don't fully understand, is how that could happen and how people in good conscience could, especially with a high risk pregnancy, could terminate their services. But I do know this happens. Dahlia can speak to that better. But this is really getting people into care earlier. So hopefully they would get more of the visits, because right now when they get in so late, they may only be getting, 4 or 5 or 6 visits, or even fewer than that. So that's a piece of the issue, but the cost to Medicaid really doesn't change.
That's interesting.
Ms. Abrams, would you mind continuing on and explaining a little bit further about those costs?
I can try. I did not know that there was a cap at 12. The way we have our incentives set up doesn't come, we don't get the best health outcomes, right? So if you can only do 12, then you don't really want to start people early on, because then you might want to have to. I think that in some clinics, they're providing all of the visits that they need to. They're just not getting reimbursed more for them. And I think it depends. There's federally qualified healthcare centers that get reimbursed differently. Part of the problem with our whole system is that we don't even know, right? Like, we're sitting here going, I think this is what's going on. I'm not sure what's going on. But if you're a clinic that's going to provide the care all the way through, regardless of what a person needs, and if it goes past that 12, you don't really want them to start early. Or maybe you do, because it's a messed up incentive. As far as the delivery cost, so when a person goes to give birth, that's the fee that gets paid to the hospital. So we have another situation where if someone comes into the hospital and they think that they're in labor, the hospital doesn't want to admit them unless they're 100% sure they're in labor. Because if they admit them and then they provide some services and then they decide they're not in labor and they send them home, they're not going to get reimbursed for any of that, right? And so we really need to be looking at a way of reimbursing for good outcomes as opposed to the number of services that are provided. But that is beyond my pay grade to be able to understand how we're going to do that. It's a really big knot. We really have, it's a really big knot the way we do healthcare. The incentives are cockeyed.
And I understand that you've worked with a lot of families, and you've worked in Alabama for a while, but your infant mortality rate and your maternal mortality rate that you discussed that we have, it doesn't account for the near misses, correct?
Right. Yes. So let me, the easiest way to show this is to show a picture. So let me see if I can get to the right picture, for what's a near miss, right? So when we look, let's see if this is going to work. Oh dear. Please excuse me as I figure out the technology here. Get to the right slide. There it is. So, you have all these windows open and then you don't know what you're doing. Here's a slide that shows the near miss situation. So when we're counting the maternal mortalities, that's like the tip of the iceberg, right? So for every person who dies, there's a whole bunch of people who almost died, right? And so if we put some numbers on that, and those are called near misses. So actual maternal deaths are 700 to 800 a year. Hopefully we're going to go back to that, getting over this COVID issue. Severe maternal morbidity, though, is 50 to 60,000 for each one of those, right? So each year we have 1.7 million birthing people who suffer a complication that has an adverse effect on their health. So really, when we talk about maternal mortality ratio, it's like the canary in the coal mine. It's like an indicator of a much bigger problem. And we use this internationally to try to understand how well we're doing with healthcare. And so when you're looking at the maternal mortality ratio in the United States, it's the highest of industrialized countries, and that Alabama is one of the highest in our country. That's just giving you the tip of the iceberg of all of the people who suffer a near miss, almost died, had a really bad hemorrhage, had really bad preeclampsia and seizures afterwards and barely had their life saved, right? There's a whole lot more of those going on. And so we have to remember those as well. Is that what you wanted?
No, that makes sense as far as when you need to get in, and how many visits. It sounds like the earlier you can get in, you would know the long-term, or the coexisting conditions. Would you be able to explain a little bit about the other conditions that may affect a pregnant person?
So, yeah, so first of all, I just want to say, because this gets really scary when we talk about it like this, most pregnancies are uncomplicated, healthy people, not a problem. When we go into anybody's had a baby, your prenatal visit is pretty short. There's not a whole lot that happens there. But what happens is critical. And so just coming in and having someone take your blood pressure, check if you're swelling, ask you if you have headaches, check your weight gain, and check how the baby's doing and listen to the baby. It takes 10 minutes, right? But those are the ways that you can identify if somebody has an underlying condition that may lead to a baby being born too soon and too small and maybe too sick to survive, or to a person having illness that's going to cause them to get into trouble and be in danger to carry that pregnancy. So we getting into that care and getting those things identified is really, really critical, even though it just takes a really short amount of time to do those clinical things.
Thank you so much for explaining that. Representative Lands, would you mind letting us know what's your next steps on this? How much support do you have, and what do you need?
Well, we do have a lot of support and good support across the aisle. I think we have about 10 co-sponsors, mostly women, but a few of our men. And I didn't go far and wide in casting the net on that. But I know that there are other folks who are going to support it. I have really tried to do due diligence in talking with all of the folks. I think Dahlia used the not word, which I use a lot, that this is a big knot, and I feel like the more I unravel it, the bigger the knot gets. But, trying to just piece together, talking with people at the hospitals, at the nursing schools, with the Department of Public Health, the Hospital Association, the Medical Association, the Maternal Task Force, Alabama Arise, League of Women Voters, so many other stakeholders, everyone that I've talked with about this bill is pretty much in support. I'd say Medicaid is probably fairly neutral about it. but we have been having conversations with them. I feel like there are other things that we are looking at doing. This is just the first thing. And as we're unraveling the knot, we've been looking at nutrition. We've been looking at the link between the intersection of mental health and maternal health. I am anxious to see what all the transforming maternal health grant is going to cover, because we've also been looking at doula reimbursement and some models of having more doulas, and even community colleges doing some training in that area. I think there's a whole lot more that needs to be done, and so we're going to continue to work on this issue and really champion maternal health wherever we can. And if anybody on the call tonight knows of other folks we should be talking to, definitely want to know about that. But I think there's so much we can do to make these birth outcomes better and to really improve lives and save money. But mostly it's about quality of life and giving our moms and our babies the support that they need.
Ms. Abrams, as a professional doula, would you mind giving us a little bit more information why that's necessary to reclassify doulas, or what could be possible in hospitals, and how to change that?
So I'm also really excited about the grant that Maryland Representative Lands just mentioned, which the name, I can't even make it come to my mouth right now. They are a number of things are championed in there: doulas, midwives, and group prenatal care. And if I could, I would like to talk about. So we need all of those. I can throw up more slides and show more statistics. If people want me to, I can do that later. But we have good data that show that doulas decrease the rate of preterm birth. We have good evidence that midwives cost less, and for low risk pregnancies, they are totally adequate. They do a great job. What we need is really good collaboration between midwives and medical professionals, so that there's an easy handoff when somebody risks out of midwifery care. We have a problem of rural hospitals closing, but we could open birth centers in the rural areas. And for low risk people, that's a fabulous solution, as long as we have good collaboration so that high risk can get pushed up. The other thing that I think is amazing is the group prenatal care model. Mm-hmm. So I mentioned that you need like 10 minutes to get your belly measured, your weight, to pee in a cup, and to have your blood pressure checked. That's easy, and that addresses the medical issues, but it doesn't address all of the social determinants of health and the educational issues and all the other stuff that pregnant people need to help them get through their pregnancy, their birth, and the early postpartum, taking care of their baby, having a new baby in the house. There's a model called group prenatal care, where people are bundled with other people who are due around the same time, and they meet in their prenatal visits with these people for like an hour. So instead of waiting an hour in the waiting room, they spend an hour with other people having babies around the same time, and they get education. And a nurse can do this, a midwife can do this, a doula can do this, can provide this information. So they're getting educated, and they're building a cohort, and they're also getting that 10-minute little visit that they need. So it's way, way more effective. And the outcomes with this for preterm birth are stunning. They reduce the preterm birth rate by 60% in some situations, which is huge. That's like bigger. Doulas is like 20-30% reduction in preterm birth rates. This is much bigger than that. It's a cost-effective, cost-saving, time-saving. Anybody would rather be doing that than just sitting in the waiting room doing nothing.
And I love this because it builds community.
It's such a wonderful model. It's being used in several places. We need to set up, again, in that knot, we have to figure out how to incentivize medical professionals to use this. The way it's set up, it's not cost effective for obstetricians to do this, the way our knot is. And so we really need to look at how we're reimbursing and what we're doing. And we need to have more midwives, more doulas. We don't need that many OBs, but we need them for the high risk cases. So that's just a nutshell of things that we could be doing. I hope that's helpful. This is a passion for me. Anybody wants to talk about how to have these things happen, I'm up for it.
Representative DeBose, we're talking about other possibilities, but you recently had a success that has already worked out. Would you mind sharing just what happened last week?
Yeah, this issue moved just unbelievably fast, and it's a lesson in how effective a personal story is to making a difference. And when I was listening to y'all, I was trying to think about, is there a personal story that we can promote that has to do with what we're working on tonight? But the issue you brought up is concerning a breastfeeding mom being almost forced to serve on jury duty. And was a young mom. It's her fifth baby. She has 5 children. She was called to jury duty. She's exclusively breastfeeding. This child, 3-month-old baby, will not take a bottle. And then, there are babies. Some of them will not take a bottle. So that's the mom. Every 2 hours has to be there for the child. She tried to get out of jury duty over the phone and was denied. She was required to come in downtown Jefferson County with her baby and sit there to be interviewed and see if she was going to be selected for jury duty. And she was treated, honestly, really pretty badly, and humiliated, and put in an unsafe condition. And she was eventually dismissed, only to be told that she would be called back again. And if she did and brought her child, they would call DHR. So it was just really disturbing. And she went on Facebook just to kind of vent, like not even really expecting anything, just trying to say, I can't believe this happened to me today. Let me share. And all of a sudden, more and more mothers started getting on there saying, yes, it's happened to me. It's happened to me. The story grew, and she eventually was given my name to call. I mean, all this happened within hours, actually. I think she called me before noon of the morning where she posted that. It was the next day. And I said, yes, I'll carry that bill. And come to find out, somebody had attempted this like in 2021, but it never made it out of committee because the committee didn't believe it was a real problem. They thought it was a solution in search of a problem. But now we know it's real because of these dozens and dozens of moms that testified and told their stories. And it was unbelievable. I think within 2 days, the Alabama Supreme Court came out with an administrative ruling that said health conditions would include breastfeeding mothers, so that judges clearly had a ruling to not have to make a breastfeeding mother sit on a jury. So we're probably still going to carry some legislation just to clarify it, just to make sure that there's not going to be a problem in the future. But, that was a situation that resolved itself quickly, as it should. And I was happy to be just a little small part of it.
It seemed very exciting. Thank you for your
Yeah,
support.
and we're going to finish that up. We've already got, I'm going to carry that in the House, April Weaver in the Senate, but we want to make sure it covers moms like up to 2 years. I mean, we want to make sure we do it right, and we're working on information and making it easy for them to have the excuse, they shouldn't have to go to a lot of trouble because they're breastfeeding. It shouldn't be burdensome proof. So we're trying to make sure that that's covered.
Thank you. Now that we're gonna about to open it up to questions, and there's been several questions already asked of y'all. But before we do, Representative Lands, would you mind telling us how listeners might specifically support this bill?
Of course. So as always, reach out to whoever your representative is and let them know. And as Representative DeBose says, it's personal notes, personal postcards, personal contact is always best, because when you are opening your emails and they're all the same exact thing, it's not that they don't count, because you certainly take note of how many you're getting, but the personal ones really mean a lot more. So reach out to folks and let them know how important this is and how this is a real opportunity for us to raise Alabama up and show that we do care about our moms and babies, because I know we do. But reach out and be involved in the process. And again, we need more women involved. Running for office or serving on boards, all those things, but at least getting involved where you can make a difference. And that means, being part of the process and reaching out to your lawmakers and being sure that, and we want to hear from you. So we're really sincere about that because we're here to serve the people that elected us. So please reach out and let us know what you care about. But for all people who care about maternal health, please reach out in support of HB 89 and urge your friends to get involved and help tell people how important it is that we pass this legislation, because the more people that we have advocating for this, the more successful we will be.
And if I could just add one thing, this goes for this bill or any bill. Whether you're for a bill or against a bill, please read the whole thing. They're online, and this is great practice just to go Alabama legislature, click on the sponsor, click on the bill number. There's lots of, I think it's fairly user friendly. If you go on there and click around, you could probably figure it out. But whether you're supporting something or not, please read the whole bill. These are not complex bills. We try to gear them to a third grade level so the average legislature can understand them. So I know y'all are, if the average legislature can understand it, then you've more than got it. But so many times I've had people mention something in a bill and they haven't read it. And this bill's really short. It's not that it's that complex, but it gives you that much more credibility. If you have read the bill and if you can refer to something in the bill, it really helps the conversation and it helps your credibility with whoever it is that you're talking to.
Thank you. Good point. Representative Lands, I see you're already busy typing an answer. Would you mind talking to us about how pregnancy Medicaid is different than normal eligibility for Medicaid?
Yes, so Medicaid, it's really not there to serve healthy adults. It's really there for people with disabilities and special conditions. And so I think for an adult to be on Medicaid as a single person, you would have to make less than $5,000 a year. But pregnancy Medicaid is very different. It's based on the poverty level, and it depends on the number of people in the home. And I don't remember the exact numbers, but for say you're a single mom, single first-time mom, it may be $26,000 a year. And for a family of four, it goes up to like $36,500. I don't remember the exact numbers. I have them, but it's a very different set of numbers. And so most women that don't have insurance probably meet those income requirements. But I think people know that they're not eligible for Medicaid. And so they think, well, that's not an option for me. And they don't realize that it is just a very different system because Medicaid is there for pregnancy and has good coverage for pregnancy.
And I'm assuming that difference is for the same reason we're talking about, improving maternal health care. I mean, this is a very crucial time.
Absolutely.
Is there, we talked earlier about the fiscal note with Representative Bose. Do you think that the fiscal note will talk about the potential savings in other areas to compare?
The fiscal note, unfortunately, only speaks of expenses. It does not talk about cost savings. So that's a sell I think we're going to have to do. But
yeah, it's not as helpful as we would like for it to be. It's not very detailed.
And they're estimates.
Mm-hmm.
And in some cases more so than others because
that's
it's
right.
Really difficult.
It will be an estimate, and it'll just be a conversation that we'll have to explain. It's going to be it's going to be tough. The fiscal note is really going to be the main conversation I think that we're going to have as far as whether we can get this passed or not. It's just from what I'm hearing already, we haven't had the increases to the budget, to the general funds, to the education trust fund that we've had the past few years. And so we're going to be tightening our belt a little bit this year. So when you're asking for more money, it's going to be tough. But look, we'll put it out there. It needs to be part of the conversation. I think that going for this bite is certainly a lot easier than going for full expanded Medicaid coverage. I think that, I know that a lot of people are supportive of that. I'm not having that conversation, but I do think that at least taking a bite at a time is being helpful. But that's going to be the biggest hurdle is the fiscal note.
I do want to just say that, we did extend Medicaid for a full year postpartum,
Yes.
and that's full coverage. And a lot
Yes.
of people don't realize that. That's huge.
That is huge. Yes. And that's what made me want to do this, because I thought, well, if we've done it for the first 12 months, we have to do it for the first 9 months. That's critical. And so to me, this was kind of a no-brainer. I'm just not happy with the fiscal note. It is what it is. And we've got smart people smarter than me calculating these things. But I still want to spend some time in making sure we're doing that correctly.
Well, and I do hope perhaps they'll revise it,
Mhm.
based on that conversation and at least, make that change to it.
Right.
And again, I think we have a good sell on how much money we could save. And so I hope we're not going to be short-sighted.
Right.
I want to just throw out a talking point that I use all the time. So a lot of times people look at pregnancy as a women's issue. And and then there are people who will say, well, I'm not having kids. I'm a guy. I'm not getting married, or my wife and I have decided not to have children. Why should I have to help pay for healthcare for people who are making a different decision than I am? And so I'm going to share in the chat that, this little quote. This is from an obstetrician researcher out of Harvard, Dr. Neil Shah. We need to stop thinking about pregnancy and birth as something that's only about women. Everybody was born, right? It's a foundational episode in the lives of all people. So when you're talking to people who are giving you that line of, well, I'm not planning to have kids, we just have to come right back at them. You're here, you were born. You needed health care when your mother was pregnant. This is about everyone.
Excellent. Yeah.
And Ms.
I love it.
Abrams, we didn't have time to talk about all the wonderful ideas that you've suggested that really would help maternal outcomes, whether near misses or the mortality rate. But would you be able to just share a little bit? You placed on the webinar chat a link to your project's impact on preterm birth. Could you share a little information about that?
Sure. So I've been doing this work for a long time. In 2011, I co-founded an organization called BirthWell Partners with Susan Petrus. I was working there until just this summer, but it's still continuing. It's a community doula program. So we know that doulas have a huge impact on health outcomes, on mental health stuff, on physical, and that's what I shared a link. So if you want to look at health outcomes, you can look there. It shows the outcomes for BirthWell Partners, but it also links to comparison in other situations, from other areas. And so we wanted doulas to be available to anyone, regardless of their ability to pay. So we've been, since 2011, building a diverse doula workforce by doing lots of doula trainings and making access to the doula training easy, equitable, free for people who couldn't afford it. And then providing free doula services for people who are on Medicaid. We started in Birmingham, but we're now serving people across the state. So that's just a little piece of it. Doulas are not medical professionals, and yet they still have a very big impact on outcomes. So that's a little thing that we can do. Money is coming into that. It's not enough, but this grant that just came to Alabama is hopefully going to make more of that happen. Hopefully, eventually, Medicaid will cover it. One thing that we could maybe do sooner is and quickly and easily, is to recognize that doulas are critical support personnel during labor and birth, so they don't get counted as one of your guests, or one of your visitors. So there's even before COVID, there was a restriction to how many people could be in the room when you were giving birth, for good reason. I think that's a good thing. You don't need everybody there watching while you have a baby. But when they restrict to 2 people or 3 people or whatever the number, or 1 person during COVID, doulas need to not be counted as one of those people. People should not have to choose between their mother, their partner, and their doula to have with them while they're having their baby. Doulas make a difference on how that birth happens. And so we really need to change
Who makes that decision? Is that a hospital decision?
It's the hospital has an overall policy. And so, for example, during COVID, the hospitals went to one visitor and they were not letting people bring, you had to choose your doula or your mom or your husband or your partner or whoever. And then Governor Ivey actually came down and said you had to allow two, and we appreciated that. And then COVID spiked and it went back down to one again. So that was a problem, except for one hospital that had a policy of doulas not counting as visitors. That was Princeton, where they're not doing births anymore. So we really need to change that. Doulas have to be recognized as critical support personnel. And you asked me who does that? The hospital policy, but under that, the doctor who's in the room, the nurse who's in the room, depending on what's going on. And they always have the right to kick people out who are misbehaving, and that's good. It should be. But doulas need to not be counted as one of those 1 or 2 or 3 visitors.
Yeah, agreed.
Representative Lands, you spoke, or there's been a couple conversations surrounding this Medicaid grant for maternal health. Would you be able to talk about this big grant that Alabama was just awarded?
A little bit. So it's, I think, Transforming Maternal Health. 15 states were awarded these grants. They came out, I think January 6th was the date they were announced. It is a 10-year grant. And I think it's about $15 million total. I have looked at the grant, but not closely. There's a lot in it, and it looks like a lot of very good things. But I know at some point doula care would be eligible for Medicaid reimbursement.
Who received that grant? Who received the grant? Medicaid. So the Medicaid has that.
Our Medicaid, Medicaid, Alabama Medicaid.
Like part of that could be used for this purpose that we're talking about in our bill.
I think it's pretty restricted about how the money is divvied out. And when I met with the commissioner, it was right after it had come out. And so they have gotten their first installment of the money, but I think there are fears that the money may not continue. So, and that's just a thing we'll have to wait and see.
True. That's always the case with federal money. It can get cut off at any time.
Yeah.
Representative DeBose, would you, I know we've talked about the fiscal note, and I know we've talked about several aspects of what other legislators will think about this and possibly object to this. Could the cost of this bill be balanced with perhaps using certified nurse midwives, or could it be balanced with other cost savings seen elsewhere?
Well, yes, certainly it could. I don't know that we're going to be able to have that evidence to help with this particular bill, but yes, using certified nurse midwives, using doulas, all these opportunities, the birthing centers that you were talking about in rural areas, I think these are all fantastic opportunities that our state needs to explore, regardless, of this bill. I mean, those are just wonderful, healthy opportunities that we need to promote statewide. I don't know if that bigger picture can come together enough to help this bill right now. But, it's all could be part of the conversation that can kind of offset what the actual cost is. I did want to address one thing that I was looking through the questions, and you were talking about, could this bill be hindered because it's carried by a member of the Democrat Party? How will Republicans feel about that? Does that kind of contaminate the bill or whatever? And, I'll say no, because I just would love to explain this to y'all. We really work together across the aisles on so many things. I don't look at, when Marilyn brings me a bill, I don't say, oh, this is a Democrat bill. I look at the substance of the bill and decide if that's something I can support. And we all do that. And, when I think about, Minority Leader Anthony Daniels, he brought 2 terrific tax cut bills 2 years ago, lowering the grocery tax and cutting state income tax on overtime pay. I mean, those were, really red meat Republican bills that he carried that we all love and support. So we work across the aisle on many, many issues. I know my friend Patrick Sellers is carrying a cell phone bill that I'm in favor of. Because I worry about kids with technology and cell phones all day long in the classroom. So we work together across the aisle many times. And I don't think the fact that somebody from, not your party is carrying the bill, I don't think that taints the bill. And I don't think that makes it any more difficult. I mean, from my perspective, I always try to give consideration to every bill, regardless of who's carrying it. And topics kind of get my attention, and this topic just got my attention.
Are there any other objections that you anticipate coming from other legislators or when this bill gets in committee?
There'll be other objections because you just can't think of everything. I mean, there will be, certainly money's going to be an issue. One thing that, I think about is, so the pay cap that is $36,000. If you make more than $36,000, you don't qualify for Medicaid. So is that going to keep somebody from getting a job that pays $45,000 a year because they want to stay on Medicaid? I mean, that's something that we always have to worry about and we always have to balance, because in our state, we really want to incentivize people to work. We have a really low workforce participation rate. And one of the arguments about expanding Medicaid is that somebody becomes dependent on it and you get that benefit cliff. And if you accept a job, then you're going to lose your Medicaid. And so that's just, that's in somebody's mindset. And we want to get people working. We want to get people employed. We have help wanted signs everywhere. We have a low workforce participation rate. So that's going to be a thought. That's, part of the whole consideration. I mean, does that make sense to y'all? If you take an entry-level job making $45,000 a year versus getting your Medicaid, I mean, there's a balances thought process that people go through. So that, I mean, I'm just saying you're asking about obstacles. That's going to be an obstacle that somebody that is not in favor of the bill could say,
Yeah.
well, that means somebody's not going to work because they're going to try to make sure they're eligible for Medicaid.
Okay. So a lot of those more complicated questions about Medicaid would be applicable.
Yeah. Those kind of things will come up.
Mm-hmm.
And there'll be other things that I can't even think of because I don't think of all those. I'm in favor of the bill, but you have to, that is smart to try to think, what is somebody going to have against it so that I can be prepared. And sometimes you just won't be able to overcome that objection. You'll just say, yes, I'm aware of that. But we think this is still more important.
And similarly, Representative Lands, is there any talk about Medicaid being extended to vulnerable women before conception, or with the general Medicaid expansion that's been discussed, would that help mothers and babies as well?
I don't know of anything that would be before conception. I certainly think that's part of our education effort that needs to be done, because I think there's a lot that people don't understand about the role of nutrition, the role of taking care of yourself, not just taking care of the baby, but good self-care. So I think there's a whole public education piece of this that we're working to try to help folks understand all the things that you need to do and to really think about these things before you get pregnant so that you're in the best shape you can be as you go into trying to have a baby.
And are there any other bills that you're currently working on or that you'd like to share about either the upcoming year or years?
Well, again, I'm looking at that intersection of mental health and maternal health. I'm looking at the neighborhood nursing programs. There's a fabulous program in Baltimore, the community-based care I'm looking at what can be done in the rural areas with telehealth and some of the other ways to deliver service with the midwives and, a whole, I think, tiered approach to this instead of it all being an OBGYN for every visit. I love the group prenatal care, but a lot of it is still in early stages where I'm trying to really research and look at what other states and even other countries are doing. I think there's a lot of best practices out there that we can learn from. So I think we have so much that we can do to improve maternal health outcomes. And it is that naughty problem, that knot that just keeps growing. So I don't know how much of it will actually happen this session. We may be ready with something on mental health or nutrition. And I certainly think we'll be able to get something going in the way of a public education campaign. I've been talking with a lot of people about that, and we've identified some funding and even have some really good ideas about what that could look like. And we want it to be something really attention grabbing. A lot of public service announcements are kind of dull. So we want it to be something that really hooks people in and gets you excited and wanting to find out more about what is available. But that won't be a legislative fix. That'll be something separate. But I think it'll be a great companion to whatever we do. And I do hope that this first bill will be really a way to bring a lot of attention to this maternal health, maternal and infant crisis we're having here in this state, and to help people really understand it, to get them more informed about it, and to help build upon that.
And if I can mention one thing, I'm working with the Alabama Department of Public Health, and this is not necessarily, well, it's definitely not legislation, but and that's working on teen pregnancy prevention. So, we've really got to do a good job educating our teens and providing resources for them. And so I'm working with our pregnancy resource centers statewide to partner with ADPH, Alabama Department of Public Health, to help educate teens, sort of a not, well, partially sex ed, because they need to understand the implications, but also if they do become pregnant, know that they have a partner and they have a somebody there that's going to help them along the way, somebody that's not going to, be judgmental or, ask questions. They're just going to be there to, if you are pregnant, they will give you a sonogram. They will help you with resources. They will help get you to the doctor. And that's kind of somebody I see that kind of help bridge the gap with some of the information that we're trying to get out about Medicaid availability. So if once we get this partnership going of statewide pregnancy resource centers, and there'll be 2 or 3 dozen of them throughout the state. We need to get them the information that these women and young girls that come in there could very well be eligible for Medicaid. And here's the questions that you can help prep them for.
Thank you all so much for your expertise, your time, and your patience with all these questions. I believe I addressed most of the questions, and if not, it's completely my fault that I didn't get them to you. But if there is any closing remarks that you want us to understand about your upcoming year and this difficulty, let us know. But I know personally that one of the biggest reasons that I am impressed every day with the League of Women Voters is it's nonpartisan, and I just can't thank you both for coming from opposite sides of the aisle for such an important issue.
Thank you for having us. This was delightful. It's my pleasure.
Thank you so much. And we appreciate everyone who's on the call, and we are here to champion Alabama's moms and babies.
I just echo what everybody said. Thanks for being here and caring and helping to get this bill over the finish line.
So I'm going to step in and just as a closing to say this has been another phenomenal forum. And I want to thank the panelists. I want to I want to thank Margaret for moderating. This is,
Great job.
not only have we learned a lot about this bill that we're about to really start pushing on to get passed, but we've learned more about the legislative process, which, every time we have these conversations, especially with legislators, to understand the process, it helps us all. And I just am very grateful. I wanted to also one of the questions we had was to say, do we have talking points? And one of the things we're doing this year that's a little bit different is we are doing what we call Take Action Tuesday. And on Tuesday morning at 6 a.m., we'll have an email that comes out to everybody on our distribution list here's your actions for the day. And you can pick which ones you want to do. You don't have to do them all, but one of the things we're going to put on there this next week is one related to this bill, because once it shows up, then we've got something to push on. Then we're working with the Reproductive Healthcare Coalition, Healthcare Accessibility Coalition, to develop the talking points that we've got some actions we can take right now, which is we heard from Representative Lands and Representative DuBose. And then we're going to be working with the talking points to help people have the language that they need to be able to give make a plea to their legislator, and also to the speaker in both the House and the Senate. Once those bills hit, that we want to talk to them about making sure that these get favorable recommendations out of committee, and through the whole system. So anyway, thank you again, and I want to thank everyone who's online for participating. And we'll send out an email with the recording. And we don't have any. We have our voter skills training coming up next month, but we'll send out emails whenever there's other forums and other educational opportunities, because this is part of what we do. We want everybody to be educated and understand the issues, and also just be able to get out there and talk to people about what the things that matter to Alabama. And so thank you, Representative Lands and Representative DuBose and Dahlia Abrams. Just really appreciate you guys. And Margaret, we'll be seeing you soon, I know. And thank you. And good night, everybody.
Margaret, great job. You're fabulous as moderating. Very good.
Thank you for the information and sharing it with us.
Thank you.
Really well.